My guest today is Dr. Howard Schubiner. He's an internist, a pediatrician, a researcher, an educator, and an author. He's a clinical professor at Michigan State University College of Human Medicine, and he's been working in the field of mind-body medicine for 2 decades. He's authored more than 100 publications in scientific journals and books. He lectures internationally, and he's consulted for the American Medical Association, the National Institute on Drug Abuse, and the National Institute on Mental Health. He's also a co-investigator of several research studies on mind-body approaches to chronic pain. He self-published 2 workbooks, Unlearn Your Pain workbook, first released in 2010, and the Unlearn Your Anxiety and Depression workbook. He's also written Hidden from View, a clinician's guide written with Dr. Alan Abbas. And his 4th book, a newly released Unlearn Your Pain, the Science of Recovery from Chronic Pain, Fatigue, Anxiety, and Depression, which came out just last week, May 26, 2026. And it's from Penguin Random House and an open field publication from Maria Shriver. And it represents a major new work drawing from his 2 decades of clinical trials and practice. He's also co-authored 2 professional textbooks, and Dr. Schubiner is also one of the co-founders and current board member of the ATNS, which stands for the Association for the Treatment of Neuroplastic Symptoms. It's a U.S. nonprofit organization which has many resources, including his podcast, The Science Behind the Symptoms, produced with Dr. Becca Kennedy. He's also played a major role in the development of innovative evidence-based treatments for chronic pain and neuroplastic symptoms. He's collaborated with colleagues including Dr. Mark Lumley, Dr. Cor Wager, Dr. Yoni Ashar, Alan Gordon, to develop both pain reprocessing therapy, PRT for short, and emotional awareness and expression therapy, EAT. Both have demonstrated significant effectiveness in randomized controlled trials on fibromyalgia, back pain, migraine, just to name a few. And EAT is now listed as a treatment option in the U.S. Department of Health and Human Services Pain Management Best Practice Interagency Task Force report, which is exciting. He's also trained thousands of clinicians and mind-body practitioners globally, and I am fortunate to be counted among them. I've been fortunate enough to see him a lot, actually, in the last few months. We saw each other at the ATNS, EAT. I was just trained by him for 5 weeks, and then just saw him in Manchester for a 2 full-day workshop. And one final thing to say, with all the credentials, all the titles, all the citation, research aside, he is the real deal. He truly cares about people in chronic pain and those suffering other chronic symptoms. He sees us in a way that many doctors don't. And I just hear on a daily basis of people that say that something that he said or a technique that he's developed or the framework like Schubiner's 7Fs or an idea that he's brought forward in a book or a podcast, etc., has helped them to heal in some way and get their life back. So I'm humbled and honored to have him here with us today. If you have migraine, you've probably been told that it's genetic, that it's incurable, that it's hormonal. You have to watch your diet, the sleep patterns, manage your stress better, all these different things. And what today's guest will say is that all of those things might have a correlation, but correlation does not mean causation. So Dr. Schubiner is one of the leading researchers and clinicians in this neuroplastic pain recovery. And today we're going to talk to him specifically about migraine and a lot of these false beliefs around what is causing them and what recovery actually looks like. So without further ado, here is my conversation with Dr. Schubiner. Welcome, Dr. Schubiner. I'm so happy that you're here and thrilled to have the opportunity to talk to you today. And
I
it's
am
right off
thrilled
the
to be here.
heels. Yeah, it's right off the heels of the new book. So I am thrilled. I got it behind me. Hopefully everybody can
Oh,
see.
wow. Yeah,
Yeah,
thank you.
so excited about that. Already bestseller on Amazon. Did you see that on 2 categories now? I saw pain management and anxiety disorders, which I thought was really cool.
Oh, I didn't
So
see
that's
that. You know what's
yeah.
funny is in England on Amazon, in the British Amazon website, it's number
Oh,
1 in a category called family and lifestyle depression. Although I'm not
interesting.
sure exactly what that is.
Never heard that one.
Yeah.
Interesting. Okay.
Anyway, it's funny.
It's doing well. That's the point. That's
You
great.
know, you put stuff out there and you hope people like it. Some people love it. Some people may hate it. You know, it's something that it's my life's work. You know, this is a legacy project. I've been doing this for a long time. And I put everything I could possibly put into this book, and hopefully it'll help some people.
I am sure it will. That was going to be one of my first questions of how this book is different than the other things that you've put out in the world.
Yeah, well, it's more in depth, I think. It's bigger, it's longer, it's got a bigger sections on the neuroscience and how the brain works. A lot of stuff on that, on placebo and nocebo effect. It's got more sections on so many of the conditions all together in one book, from the chronic pain conditions to the chronic fatigue conditions to the emerging, so to speak, emerging conditions that are becoming more prevalent nowadays. It's got a whole treatment section, so it's just pretty inclusive. It has over 800 medical references, and
I love that. Yeah.
I tried to make it a book of science that reads well.
And it does. Very, very, I love it. And I do love all the things that you have cited. There's no denying the science behind it. And also just very easy to read with all the personal stories. And yeah, love it.
And the research we've done, so it really includes the up-to-date research that we've done, randomized controlled trials, showing that this work is effective. So that's, I'm really proud to be able to put that into book format.
Mm-hmm, mm-hmm. So what I wanted to do today, because I know you're interviewing with a lot of people, you've got a lot of information out on the internet about how one learns pain essentially and how to unlearn pain. And what I wanted to focus on today, since our podcast is focused on migraine, is to just kind of go into the migraine nuances. In the migraine community, we got a lot of ideas of what is, or we're told actually by physicians that this is being caused by a lot of external things. And so the book goes into it a lot. I want to go into more detail on some of the things. But the first question I have is just, you've had a lot of experience over 2 decades of working with patients, and surely you've seen a lot of migraine patients. That was actually one of your first stories in the book, of having somebody with chronic headache that had recovered. And so I was just wondering, is there any pattern specifically to migraine that you see, or specific things that migraine population worries about, or is different in the healing? Or do you see this as all kind of one neuroplastic symptom?
We know that the epidemiology of migraine is the same as the epidemiology of other neuroplastic disorders, occurring in young people, teens, even children, of course, young people in their 20s, 30s, and 40s, primarily, occurring in people who've had histories of emotional trauma or emotional stress, a fair amount of stressful life experiences. It's seen in association with other neuroplastic conditions. So people with migraine often also have or have had irritable bowel syndrome, fibromyalgia, anxiety, depression, etc. We see a lot of these that come and go, where someone may have migraine, have been suffering with migraine for several years, and then it kind of goes away, and a different neuroplastic condition sort of takes its place, and then the migraine can come back a few years later. The intermittency of it is one of the telltale signs of a neuroplastic condition. So I don't see it. I mean, I don't see the type of personality traits associated with it as different. Those are the same we see in other neuroplastic conditions. The severity can be from mild and episodic to chronic and severe and debilitating daily headaches, and still be migraine. But given all that, we treat it the same way, and we've had success in treating migraine using the same methods that I put in the book.
And I like the fact that the book has all these different symptoms that you were mentioning, that it's one place that connects the dots between my depression actually had the same root cause as the migraine, as did later my burnout. And then it sort of was this culmination of putting all those dots together to say, actually, that was the same root cause. And the beauty of that is it's the same way out. or to
Yeah.
unlearn.
Yeah, I think it's really helpful to think of it that way. So you're not thinking of it as being incurable. You're not thinking of migraine as being worse than anything else or different than the other neuroplastic conditions, but as part of the continuum of them and as part of being human. And I'm definitely not trying to minimize migraine. That's the last thing I would do. One of the things I write about in the book is how severe and debilitating it can be. This is well known. We've seen a lot of people in that situation. One of the people on our board, the ATNS board, is Lee Cantor, and he was 8 years with debilitating migraine, bed bound for many of those. I mean, really, really severe, and doing well now. So.
Yeah. Can I touch on one thing that you just mentioned, that there is this wide spectrum of having dull headaches to episodic migraine, then chronic migraine, all the way to daily.
Mhm.
So does that mean that the neural circuit has really been enforced and is a stronger neural pathway? Or is that a correlation of the progression of it being daily from dull headache? Because mine got more dull as I went
Mm.
on. And I was thinking, okay, is this a neural pathway that's then losing strength, or how does that work?
Yeah, it's a great question. I don't think we know the answer to that. When I think about neural pathways, or I like to call them neural circuits most of the time, there's a different neural circuit for different types of headaches. And they can turn on and off. And so the type of migraine that you may have had earlier and then it shifted to a different type of migraine is, I would say, a different neural circuit. It's not that one neural circuit is getting less. I would
Okay.
consider it a different neural circuit. So you have these neural circuits for sharp intermittent pains, different neural circuits for these dull pains. And when people have migraine, they can have it on one side of the head or the other side of the head, right? And that can alternate. Some people have it only on one side, for example. But if you have it on one side and then the other side, that's a different neural circuit,
Okay.
right?
I
So
think I got
sometimes, a lot of times people say, well, sometimes my headaches are more here and sometimes they're back here. Those are different neural circuits. And if you think of the brain as having a soundboard, what you would see in a music studio with a soundboard with loads of dials that can all go up and down, the brain can control each of those sensations independently. And so that's, I think, a good way to think of that. And it really reinforces the idea that these are neural circuits, that the brain is turning them on and turning them off and shifting them and making some stronger and making some lighter at different points. And it always has that capacity. The brain has that capacity to do that, because once those circuits have been learned, they're not too hard to go back to.
So my immediate thought, and the thought of people on listening potentially, is I thought this was one migraine neural pathway that I'm working on, and oh no, is he saying that there's hundreds of them that I so
It's
I'm
just,
sure
that's
that
how the
just
brain
scared
works.
people more.
But they're all controlled by a central. The way I think of it is they're all controlled by a central danger signal.
Yeah.
Does our brain feel safe or in danger? The brain works in this dual mode, safe or danger. When you walk down the street, it's looking at every person, safety, friend or foe, safe or dangerous. Our brain is constantly trying to protect us and predicting what it should do. And so when we go through life, it is very well known that emotions are related to the danger signal. This is hard neuroscience. And so as we go through our day, as things happen to us, our brain can interpret a glass of red wine as dangerous, or a chocolate Hershey's Kiss as dangerous, or it might interpret going to a loud event like a concert as dangerous, or it might interpret going to work as dangerous, or it might interpret going to a pub or a bar as not dangerous at all. And it might interpret having a glass of wine as dangerous one day and not dangerous the other day. So those neural circuits are fluid, and the brain is there to try to kind of help us navigate life. And for people with migraine and the other neuroplastic conditions, the brain has learned to turn those circuits on in response to certain things that happen in our life. And because it's learned, it can be unlearned, it can be changed.
Mm-hmm. Mm-hmm. And the goal is to bring more safety into the system.
Yeah, to really kind of teach our brain that chocolate is not dangerous, that wine is not dangerous, that concerts are not dangerous, that work is not dangerous if it's not. And if it is dangerous, changing the work or changing something about the work or changing our relationship to it so that we make it less dangerous, so that our brain will not give us an alarm. Because the danger signal is like a smoke alarm. And, it's not betraying us, it's trying to alert us to some danger. In the case of a smoke alarm, it's smoke. But in the case of migraine and danger signal and other neuroplastic conditions, it's things that are perceived as dangerous by our brain through whatever it's learned in our life.
Mm-hmm. And migraine is a little bit different from some of the other chronic pain conditions as far as there's measurable changes going on in the brain, in the body. And so I was just wondering if you can explain from a medical standpoint what's happening in the body and those mechanisms through the mind body lens as you do
Yeah,
that, if you could.
yeah, great question. So I would say that almost all the time there are physiologic mechanisms going on in our bodies when we have neuroplastic conditions. For example, phantom limb syndrome is probably an exception to that, because people with phantom limb syndrome are having pain in a foot that has been amputated. So there's no physiologic changes going on in the foot. All the changes are occurring in the brain to create that pain. But in irritable bowel syndrome, people have diarrhea, constipation, bloating, gas. All of those are associated with physiologic changes in the gut, with hormonal changes, with neurotransmitter changes, with changes in the autonomic nervous system. There's a lot of things that happen that are real and physiologic, but I would suggest those are not pathologic changes. In ulcerative colitis, there's high levels of inflammation in the bowel. That's a pathologic change, a structural change, tissue damage, injury in the bowel. Whereas with irritable bowel syndrome, the changes are physiologic. They can turn on and they can turn off. They're not tissue injury. And migraine, I would suggest, is similar. There is no question that there's physiologic changes going on in the brain, cortical spreading depression. This sounds horrible. And when you talk to neurologists, they say, well, that's the same kind of thing you see in epilepsy. And so clearly, migraine starts in the brain. Something happens to trigger the brain to create the variety of sensations that occur that are very individual to each person. They can be aura, can be picket fences, all sorts of visual changes, the types of pain, the type of throbbing, the location. All those are very individual and often similar in certain people. Certain people will get the same one over and over again, but often they will vary. But the point is that something's triggering that in the beginning, right? There's physiologic changes that are happening, but those are not tissue damage changes. In epilepsy, there's damage in the brain that causes the brain to trigger seizures. But in migraine, there's no damage in the brain. These are neural circuits that have been learned. And so the fact that CGRP inhibitor medications can work for migraine tells us that's part of the pathway that the brain goes through to create migraine. And you can block it for some people by giving these medications. Similarly, in irritable bowel syndrome, you can block some of the pathways to diarrhea by giving anti-diarrheal medications. but
Mm-hmm.
you're reaching it at the end, not at the beginning. The
The
beginning
root
is something,
cause.
yeah, you're not getting to the root cause.
Yeah.
And so I'm not against using medications for people. I don't want to see people in pain. I don't want to see people suffering. These new medications have helped a lot of people. But what's interesting about the CGRP inhibitor medications is that when you do studies of them, the average reduction in one of the studies anyway, but similar, the average reduction in migraine headaches per month was about 6.2 reduction in days per month, of migraine days per month. That's a pretty strong effect. But in the placebo arm of that study, there was an average decrease of migraine days of 4 per month. That's a pretty high
Right.
placebo effect. And when you
Right.
see medications with a high placebo effect, to me, this is a really good sign because it's telling us that we can use the power of our brains to change migraine. We can use the power of changing our neural circuits because placebo effect is real. Placebo effect is changing neural circuits in the brain. So it's not, the difference isn't 6 migraine days versus 0 with placebo. It's relatively small difference. So the medications can be dramatic and can be great, but they can be expensive. They can have side effects, and not everybody, wants to take medications. So if there's a way of, as you pointed out, getting at the root cause and stopping the migraine before it turns into cortical spreading depression, before it activates CGRP pathways, that would be great.
Mm-hmm. Mm-hmm. And Dan Kaufman was on the podcast a few weeks ago. We talked about
Okay.
his study with EAET and the
Right.
results. And I was saying to him, it's a different. He was very conservative with how excited he allowed me to be, I think. But from the preliminary results, he kept saying, but when you look at the results from that to what the CGRP averages are, it was sort of like, okay, well, this is because it always fascinated me working in pharma, why we were allowed to say that we had 6.2 reduction when the placebo was this 4, whatever. It's like, shouldn't we have
Yeah.
to minus that out? Like, that doesn't seem fair to be able to, it seemed over exaggerated, what
Yeah.
the actual
Yeah.
increase was. But anyway, with the
Yeah.
AAT, it was shown to be, and I was trying to explain to him,
Yeah.
yeah, I mean, coming from a pharma side, we'd be throwing all kinds of money at that if that was a compound and trying to,
Yeah.
like, ooh, we have the next blockbuster, right?
Yeah.
But
Pretty powerful effects. The Botox
yeah.
story is fascinating because Botox is giving a medication to the, skin, the subcutaneous tissue and the muscles of the face, forehead, neck, and, around. But migraine starts within the brain, right? It doesn't start in the muscles in the face or the neck. And so by giving Botox, the mechanism, it's not clear how that actually makes sense to stop migraine. And when you look at the difference in the research studies between the Botox versus placebo Botox, there's very small. We're talking about 6 versus 5 even.
Mm-hmm.
And so it's very little. And people who have written about Botox kind of wonder, like, how did that get approved? It's
Mm.
it's very small effect, and it seems to be primarily a placebo effect by far. But again, that's a good thing from my point of view. And if it works, fine. People like it, et cetera. If it works for people, that's great. But when you realize that the placebo effect is that high in the research studies, that tells us that we could probably do a lot with retraining our brains.
Mm. It's funny because I had a client recently, I had sent them to your podcast, The Science Behind the Symptoms, on that
Mm.
episode with placebo and nocebo.
Oh yeah.
And she came back with a comment that how foolish she felt. And that was this all just, she was making it up then, or that it wasn't really the medication that she just, and I was trying to say, no, this is how I see it anyway, is that this is just one more example of the power of the brain that we can
Yeah.
harness, that we can use the placebo effect to our advantage versus the nocebo being aware of that understanding the thoughts also about, oh, that's not going to work. I've had that happen to me as well.
Right.
So,
Oh, yeah. I mean, I consider myself a placebo doctor. Placebo is not a dirty word. I'm not a huge Joe Dispenza fan, but I think he's done a lot of good and a lot of good work. And one of his books is called "You Are the Placebo," and
mhm.
it's really quite a good. The first half of it, anyway, is really quite good, I thought, and explaining that we can harness the power of our own brains. And placebo is actually making changes in neural circuits in the brain. So it's a positive and powerful thing that we
Mm,
can use, and we do use all the time.
yeah. I was actually talking to a different client, and she was telling me that they had this Botox lifestyle compliance that she had to agree to each time she went for the Botox. She had to agree that she was lifestyle compliant. And I said, well, what does that entail? I had printed out some things. This is not from the actual, and this is from the UK. So maybe this is specific to them, but that limiting or no caffeine, no paracetamol, more than 10 to 15 days a month, making sure there was no meals skipped, especially breakfast, like all these
Oh,
different
geez.
managing stress, no alcohol or reducing it greatly, tracking their menstrual cycle. And I just thought, what a recipe for hypervigilance
Yeah,
and causing a migraine. You know what I mean?
I
So,
know. It just makes you
um,
afraid. It's so fearful. It's a fear.
yeah,
It's a way of living your life in fear. And research has shown that the more you track pain with pain diaries, the worse it gets.
interesting. I didn't know there were
Yeah.
studies on that.
Yeah,
Well, that
there
was
was.
going to be
Yeah.
one of my
Yeah.
questions because for me, I had to track when I was on a CGRP because I needed 8 or more a month, or else I would be kicked off at it at some point. And in Switzerland,
Right.
it was when they first came out, there were a lot of rules about how I could get on it. And then each year we would be forced off of the medication actually
Mm.
to see if it was still needed, I
Yeah.
guess. I don't know. But
Okay.
that
Yeah.
first year I was frantic and just talk about the fear response and just crying in the
Mm.
pharmacist. I'll pay anything to get this drug. I need this drug. It was finally helping me. So I really look back and say, oh my gosh, I see such a transformation from that to then the next year, me telling my neurologist, I bet you I'm not going to even go back on it after this break. I found the mind body approach. I don't need it. And then, but the fear and the tracking of it, and gosh, I have Excel spreadsheets like you wouldn't believe, or I had an app to track the barometric pressure because,
Oh my
and that
God.
I
Yeah.
look back
Yeah.
on that and I'm thinking, why was I doing that? Because yes, I knew when the storm was coming and I anticipated the problem, but what actually did I think that was helping? Because I can't control the weather. So that one I hear a lot with the barometric
Yeah.
pressure
Yeah.
and
Yeah.
yeah.
There's been a lot of
Men-
studies on weather and barometric pressure, and the best design studies show, from my reading of the literature, is that weather does not actually cause pain in and of itself. In other words, weather and in migraine, chocolate, wines, foods, lack of sleep, dehydration are,
So
in
many.
my view, all causing through conditioned responses, all triggering migraine or other symptoms because the brain has learned to associate those with the symptoms. And the brain is very good at seeing those and predicting those and even seeing those ahead of time. And our brains are probably really good at detecting barometric pressure changes. We seems like we've seen that. And so the brain has a way of, because of its protective functioning and predictive processing, meaning it's trying to predict ahead of time. And so
Mm,
one of the things that we do as part of our assessments is we ask people to imagine the trigger, imagine the weather changing, imagine eating chocolate, imagine having that glass of wine, imagine waking up and having not slept all night, imagine how that feels. And often the brain will start to turn on a migraine just by
mm,
imagining that situation, because the brain is sensitive to that. It's predicting that will do it, and then it's actually creating it. And when you see that the brain creates some of the symptoms of migraine by just imagining it, the trigger, you can begin to see, oh my goodness, it's not actually the trigger, it's the brain's response to the trigger. And that can make all the difference in the world, because that can be so freeing when you learn to unlearn, or when you can unlearn those triggers.
Right. I've heard many times that, I'll just use myself as an example. So wine was a huge conditioned response. I could
Yeah.
have one, but not two glasses. And
Mm.
I was so sure, this is embarrassing to even say, but I would take a Triptan sometimes at night before bed to make sure that I was not in pain, to make sure I didn't wake up in pain because I was
Mm.
skiing that weekend or I was having to go to work and something was important. So I was so conditioned. Even when I was out to dinner with friends, a waiter would come by and my friend covered over my glass and said, no, she can't have a second glass. She'll get a migraine. I mean,
Mm.
everybody knew it. I was the migraine girl. I was two glasses of wine. No, that was not what I could do. And then I realized this conditioned response. And then I started feeling better after doing all this type of work that you're explaining in this book. And then it became a non-issue. I drank what I'm not really a big drinker anyway, but I drank what I wanted. When I went out to dinner, I would, not an issue at all. And then it's funny because at some point, and I think I've heard this often, that sometimes then you have the little thought when you get the glass of wine, like, oh, I hope that's not going to be a problem. Or
Mm.
you have that
Yeah.
like little doubt. And I always wonder, is that enough that is making the brain scared? Because then I'm going into safety, like, no, we've not had a problem with this in the past. And this isn't, you know, where's that like tipping point when the brain gets so scared that it actually produces the pain?
Yeah. Yeah, we don't want to be living our life in fear of having a thought either, right? We don't want to be so, as you pointed out before, so hypervigilant, so fearful that this other glass of wine, or even if I had a bad thought, oh my God, that's going to trigger a migraine, then, it's horrible. It's just a horrible way to live. We have to recognize that we do everything that we can to make ourselves feel safe and secure, everything we need to do to deal with stress and emotional issues that you talked about with Dan Kaufman, uh, everything that we can do to have a positive attitude and not be fearful. But, we're going to have scary thoughts. We're going to have fearful thoughts. And if we can just notice them and smile and not worry if it's going to be a problem or not. And, if it does cause a migraine, so it does, we just can't live in fear so much, because that can really create a negative spiral.
Yeah, I think this is one of the things that is a difficult thing to tackle, a little bit of explaining that, but then also really embodying that because it is scary. And,
Yeah.
people
Yeah.
are starting to feel better and they don't want to. So it's a little bit of a human nature to, have those thoughts, but it's also
Right.
doesn't
Right.
mean that it's going to lead you down the road of a
Yeah.
pain.
I mean, probably the most powerful psychological mechanism of lowering fear, because fear is highly associated with migraine and other neuroplastic disorders. The most powerful psychological way of lowering fear is paradoxical intention, which means tell your brain you want it, you want the migraine. Tell your brain you're not afraid of it. Tell your brain, I don't care. Instead of I'm safe, don't give me a migraine, don't give me a migraine. That's fearful thinking, really, right?
Yeah, yeah, yeah.
I don't want it. I can't handle it. I don't want, of course you don't want it. It's horrible. These are not good things. I'm not saying they're great. I'm not making light of it, but the most powerful way is to say, I can handle it. I'm not afraid of it. I don't care. I
Mm-hmm.
will be fine no matter what. If I get it, if I don't get it, I'm going to be fine. That is the most powerful thing that people can do. And it
Mm-hmm.
takes courage. It's hard.
Mm-hmm.
Yeah.
Yeah, that's great advice. Great advice. So I had posed on my online community to see if anybody had questions. So let me do a couple of those. Um, One asked, even when I'm not having active pain episode, I always have some level of headache. Is this a residual pain from the migraine, or is that some neuroplastic process running at a lower level? I think you may have
Yeah,
explained that.
I think it's a separate neural circuit that's going on there. And again, I'm not saying we need a totally different way of addressing it, But I think addressing it as simply another neural circuit that the brain can turn on and can turn off is the way to go.
The genetic factor, I want to just briefly touch on because it's such a huge thing in this community, although you've written so much about it in the book that I don't think we really need to go into depth. But this notion of epigenetic genes and the fact that stress and emotional challenges can be responsible for turning them on or the gene expressing. I just wanted to see if you can kind of talk about that. You mentioned that with migraine, it's the case, as well as anxiety and depression, which I see a lot in people
Yeah.
with migraine. But can you just kind of
Yeah.
uh,
Yeah, for
talk
sure.
about
There's a lot of misunderstanding of genetics. Mendelian genetics, sickle cell anemia, cystic fibrosis, muscular dystrophy are genes that if you get those genes, you're going to get the disease. And it varies to some degree, but it's very strong association. In migraine, familial hemiplegic migraine is strongly genetic. That form of migraine is strongly
that's
genetic.
rare,
Yeah,
correct?
but it's not common. Yeah.
Yeah. Okay.
The but when you if you say you want to go to the doctor or send your blood in for genetic testing, I want to see, well, do I have a risk of Alzheimer's? Do I have a risk of Parkinson's? Do I have a risk of different cancers? You are going to find genes associated, that everybody has some of these genes associated with some of these disorders. But that doesn't mean you're going to get it. It's a predisposition. And so with migraine, that's exactly what it is. There are many genes associated with migraine at a very low level association. They are predispositions to get migraine, but people will not necessarily get migraine just because they have those genes. And the
Mm-hmm.
idea of epigenetics means that genes can be turned on and turned off. What causes genes to be turned on and turned off? Laughter causes epigenetic changes in genes. Meditation causes epigenetic changes in genes. Stress causes epigenetic changes in genes. And so when you think about things that we do in our life that make our genes more or less likely to turn on certain conditions, we actually have control over a lot of them, more control than one might think. When someone hears
Mm-hmm.
it's genetic, it kind of means, oh, I have no control over it. It's all genetic. But
Yes.
because in migraine and in anxiety conditions and depression as well, understanding the epigenetic nature of these disorders actually informs us to think we have more control rather than less control, because these genes can be altered by our lives and how we live. And that's amazing. And
Mm-hmm.
and it's very positive. It's not doom and gloom that there's a genetic component. It's a positive thing.
Yeah, this was me, I won't say how many years ago, but many years ago, hearing that at 17, it was that's it. This is your genes, you're done. You're going to pass it along to your kids probably. As soon
Yeah.
as I mentioned that I had depression, my mother was almost like, "Oh yeah, I've been just I mean, she didn't say this, but
Mhm.
paraphrasing, sort of like I've been just waiting for that to happen because every female in our family has a anxiety or a depression issue." And it was like, "What?" Just like that's your fate as well. Yeah, we've got crappy genes. She would always say that we've got crappy genes.
Oh,
I really felt that way and made life decisions based on that. I have another podcast episode where I get emotional on that because yeah, I didn't date people who wanted families. I made decisions not to have kids. I really kind of went overboard, but nobody
wow.
was talking about epigenetics back then. So it's
Yeah,
like
yeah. It's
just
also
pass this along.
modeling. I mean, the brain, when we're under stress and the brain feels endangered, it often will send a message of danger. That message could be stomach pain. If you're speaking in front of a big audience, your stomach might turn into knots. Stressful day at work, you may get a headache. You may get foot pain, back pain. The brain can turn on any of these warning signs or messages, so to speak, when we're under stress. Now, why would it choose one or the other? One of the reasons the brain will tend to choose one particular type of condition in a certain person is what is in their family. In other words, it's a modeling effect. Oh, my mom had headaches. So your brain will go, well, I'll give you headaches. When my mom had irritable bowel, your brain will go, I'll give you irritable bowel. And it's not necessarily genetic at all in any way, shape, or form. It's a question of what we would call modeling. For example,
Mm-hmm,
with
mm-hmm,
anxiety, we know that anxiety is more common in boys whose fathers have anxiety and more common in girls whose mothers had anxiety, which is actually
hmm.
not genetic. That's a modeling effect.
Interesting. And we're talking about stress as one of the components that can flip that switch or have the gene express. And you talk a lot in the book about childhood trauma and increasing the migraine risk and how later stress
Right.
can trigger this onset. Can you help us understand how early life experiences of that kind has such a long reach in the body, sometimes decades later, and how that kind of works?
Yeah, just think about anything that you were exposed to that was scary in childhood. You tend to remember that. The brain works by danger, and danger and fear is deeply embedded into our psyche. That's how we learn. And so if you learn that uh, in Sanjay Gupta's book, he talks about jumping over a fence when he was a kid, getting impaled on the fence. The fence is like ripping his, chest open, his horrible pain. What do you think he's going to think about the next time he jumps over a fence? Come on, that's going to last for years and years. And
Mm-hmm.
everybody has those situations where they had something scary happen in relation to a specific situation. With trauma, it's often in relation to a specific person. One of the most amazing stories in my book is about a woman who had a father who was kind and great most of the time, but some days he'd come home from work, be really angry, mad, yelling, screaming, even shaking people. And that caused her brain to have that powerful memory of that fearful encounter. 30 years later, when she got a boss who was the same way, he was fine most of the time, but her boss would start yelling for little reason, yelling, screaming, debasing people, belittling people in the workplace, including her. Her brain turned on headache. She never had headaches
Mm-hmm.
before, but her brain had felt a need to send a message. There was something wrong. And the point is that it remembered a very specific type of fearful situation with an older,
Mm-hmm.
powerful male being dominant and being scary. This happens in so many ways to people.
Yeah, it's amazing. One of the biggest learnings that I had was that I just always thought stress was what I saw around in my life. Like my job was very, very stressful. My relationship was stressful. That's what I thought was stress. And for me, anyway, and I hear this often, that going into the doctor and them telling you, well, you need to manage your stress or this might be stress related, it does feel a bit dismissive. And I
Yeah.
really was sort of like, well, I'm so stressed that I can't figure out how to manage my stress. You know what I mean? I have no time for that. Like, meditate? Like, what are you talking about? And so, one of the biggest learnings was that stress is so many different things. It comes in so many different forms from the emotions, from the personality traits that we have learned or the learned coping mechanisms that I call them, the perfectionism and all these things that we're putting pressure on ourselves and the tension and but just how much is going on in the subconscious mind that it's just going under the radar and these childhood things and all these. So it's yeah, that's been a big eye opener.
Yeah, exactly. Yeah, exactly. And it doesn't mean everybody has to go live on a tropical island to be stress free to live our lives. Stress occurs in our
Mm-hmm.
lives. Everyone has stress. And the
Yeah.
people who do the best are those who have the belief that they can handle the stresses that they have. This is very well shown in high
Mm-hmm.
quality research studies. And so
Yeah.
we're not going to have people live stress free lives. What we're going to have people do is recognize that migraine and other neuroplastic conditions are reversible, are caused by life events that have occurred, that have been learned, and that can be unlearned by dealing better with stress, by recognizing that these are neural circuits that can change, and doing things to deal with emotional situations, but also doing things to make our brain less fearful of the triggers that we talked about earlier.
Mm-hmm. One thing that I really recognize now, of course, in hindsight, it's easier. But when I was in that depth of, 17 migraines a month and just like at the height of just absolutely feeling terrible, the message in my brain every day, probably 200 times would not be an exaggeration,
Mm,
was I'm so overwhelmed. I'm so overwhelmed. I can't take it. I can't take it. It's too much. It's too much
yeah,
all day long.
yeah,
So, I mean, now looking back in hindsight, it's like, I mean, no wonder I was scaring my brain like every 5 seconds. So, yeah,
yeah. I
I
mean, every
operate.
time one of the things I write about in the book is that when the brain sends out a sensation or a symptom, it's also sending out a question. And the question is something like, are you okay?
Mm,
Are you okay? How are you? Because the brain is a black box. It doesn't really see, it doesn't have eyes. The danger signal is deep in our subconscious. All these things
mm,
influence it, but it needs feedback. And the feedback that we give it, that you were mentioning, Karen, the feedback of, no, this is horrible. I can't take it. I can't live another day. I'm lost. This will never recur. Those are messages the brain takes in. And
mhm.
those are scary messages to the brain. So, what else is the brain going to do but turn on more danger, actually make the migraine worse? Because then, and we're
Yeah,
not blaming people, it's not people's fault. Everybody has those thoughts.
yeah, absolutely. Yeah.
What we're just trying to do is teach people that they can have more control over their subconscious brain by giving the brain messages of safety, by giving the brain messages of ease and freedom and hope, and giving the brain messages of less fearfulness.
Hmm. And we're not talking about toxic positivity here of just saying, oh, I'm going to be fine. Yeah, it's perfect. Everything's great,
Yeah, right.
because the brain's not going to believe that, but making it in just such a way that it's feeling this way at the moment, or just making it so that it's believable enough to soften
Yeah.
that impact, I guess.
Yeah,
Yeah.
it's hard because when you're in pain, when you're in anxiety or fatigue or depression, when you're feeling these things, it can be overwhelming. It can be really strong. And to say, I'm fine, there's not a problem, is kind of lying to yourself. There is a problem. But what you're trying to tell your brain is, I have the resources to handle this. I have hope about this. I can handle this right now. I'm going to be okay. I'm going to be the best I can possibly be right now in this moment, even though I'm in pain, even though I'm suffering. But I'm going to step back from that just a bit to take some of the pressure off and give my brain the message, I'm actually all right. Yes, I'm in
Mm-hmm.
pain, but I'm actually okay on the deepest level. I'm actually okay. I'm not damaged. I'm not broken. There is hope.
Mm-hmm. This leads perfectly into another question that came in from online. And that is, when I'm in the middle of severe, she calls it an attack.
Mm-hmm.
I'm really careful with words, and
Mm-hmm.
really like to, because I don't want to think of the brain or the body attacking me or having to be a migraine warrior. It's a communication, it's a message. So I usually change that to episode or a pain episode, that kind of thing.
Sure. Sure.
But so when I'm in the middle of this, though, vomiting, completely incapacitated, do I need to keep pushing through normal activity to signal safety to my brain, or is rest appropriate?
I think everybody has to be kind to themselves. If you're beating yourself up, if you're pushing through something with fear and horror, and it's so bad and you're dragging yourself, I think it's appropriate to rest. There's rest is important. Your brain is sending you a powerful message. It's telling you to rest. And you're saying, okay, I get it. I'm going to rest, and I'm going to do what I can to change the neural circuits going forward. So on the other hand, we have had people who were able to abort attacks by recognizing an underlying emotion. When an episode occurs, it might be very wise to stop and say, what's going on here for a moment? Did something just happen? Is there some feeling I'm having? Am I feeling guilty about something? Am I feeling resentful or angry about something? Do I feel I betrayed myself? A woman I saw the other day had a huge rise in pain after having lunch with a friend. And when the pain came up, she recognized that her friend had asked her to do something and she had said yes, because she
Mm.
always says yes and she never said no, and
Mm.
she never says no. And she realized at that moment she felt she had betrayed herself, because deep in her heart she had just wanted to say, no, I can't do that. And she called up
Yeah.
her friend with fear in her voice and said, no, I'm sorry, I can't do that. And she felt a little pride and her pain went
Hmm.
down immediately. So,
Yeah. Amazing.
checking in for an emotional trigger for the onset of a migraine or other neuroplastic conditions can be a really wise and thing to do, which often can be addressed right in the moment.
Hmm.
And then sometimes you don't want to always, I don't think, always say, oh, I'm feeling the start of a migraine, I don't want to go out, I better not, I better not do anything, because then you're reinforcing to your brain that you can't handle this, and your brain is like, yeah, okay, well, I guess so, and then keep going. But sometimes you do, at some points we do want to teach our brain that we can go out and we can enjoy ourselves even in the midst of some of the symptoms, hopefully ones that are not that severe though.
And that's how I explain it, is that it's sort of like somatic tracking. You do that up to a certain pain level. So once you can't be neutral about it anymore, that's not when you're
Right.
meant to do somatic tracking. And so what
Right.
I'm always saying is that, yes, we're trying to send messages of safety, go out, have a walk, do what you can, as maybe, my shoulders would always tell me the first kind of sign, or I would have blurred
Mhm.
vision, or I kind of could recognize the signs of it coming. And what had changed so much was, before I would panic, freak out, say, oh no, I have to change my calendar and I'm going to be in trouble because I can't get that done. And that person is going to be mad that I haven't done that. And I went into bed with the ice pack and the head stuff. And I mean, it just was this big to do. And then as I was healing, it was more, okay, I'm going to just go out for a walk and I feel
Mhm.
okay. It doesn't mean that it has to escalate. I have been able to a couple times abort it when
Mhm.
I found the emotion behind it. I will say that that got to be, I got hypervigilant about that and mad that I couldn't find it then in other times. So you have to be a little bit careful on that, because
Yeah,
then,
for
if you
sure.
if you do it once and then it's like, well, I must be doing it wrong. I couldn't find it this time. And yeah,
Yeah,
so
you
that's a little
can't
bit of a
always
slippery.
find that. Yeah, you're
Yeah, yeah,
absolutely
that's,
right. You can't always find that. There's going to be times where you say, I don't know, my brain just did it. And that's, so
yeah,
we
you
just
need
have
to
to
let it
train our
go at
brain
that
out of
point.
it. Yeah. Yeah. I've seen people who obsessed to some degree about finding, oh, what was I thinking? Did I think something
Yeah.
wrong? Or what did somebody say? Or trying to think back, like, well, 6 days ago, I had this encounter. Sometimes you just don't know.
Hmm. Or I say, after you're feeling well, then maybe go back also and think about it. But when it gets to the tipping point where the pain is so intense, like she's talking about vomiting and really being ill, that's when I say self-care, absolute self-care. But then the mindset is
Yeah.
out of a lens of safety and self-compassion, and
Right.
instead of fear. So it's, yes, get the ice pack if that's what you feel like you need, but it's of, hey, I'm doing this to soothe myself, not out
Yeah.
of, I have to do this because it's the worst thing ever kind of thing.
Yeah.
And that
I
helps.
agree.
I
Yeah.
think you've already touched on this one. There was one other question from the community of, how does fear and symptom monitoring unintentionally keep migraine circuit alive? I think we did talk about
Yeah,
that
it's
with
just
the
sending a
apps.
dangerous, yeah, it's sending a danger signal to the brain by really trying to look for it and monitor it and think about it. And yeah.
There was one other question about medication overuse. And she asked, I would love to know if he thinks medication overuse headache is a thing, or if it's mind body because we're told it's a problem, then maybe fear of overusing is what causes the actual problem. And a follow up to that is, if it is real, do we need to bear the discomfort of stopping the medication, or are there other alternatives?
Yeah, it's confusing. I don't think anyone really knows. It's been written about a lot that overusing medication can cause more headaches, or withdrawal from medication can cause headaches. And I think that for the most part, because the headaches are neuroplastic, where really the most important component is danger to the brain, perceived danger to the brain. And so I think that just not worrying about that too much is probably a good move. I mean, I'm not saying we should totally ignore those concepts, but focusing on them and worrying about them and monitoring them at a high level of fearfulness is not going to be helpful.
I know for myself, when I started getting close to that number that I was told not to cross, then it was this pain, fear, pain cycle. And I was very hypervigilant about it and really worried that the pain was going to come. And what did that mean? And was I not allowed to take the pill? And da, 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 da. So it really, one of the things that I shifted was really tracking it in a very different way of just like maybe a dot on my calendar, not like making a huge spreadsheet and being so hyper. I mean, I was a little bit nutty. And then really just sending messages, safety to, that's not going to happen. It's not a problem. I'm safe, all these kind of things, and doing all the things that are in your book as far as how to unlearn the pain. You're doing that all along anyway. And it's
Yeah.
hopefully making a difference. Yeah.
Yeah. I agree.
Is there anything else that you think that we should touch on with the topic of migraine that we haven't touched on, or anything from the book that you
Yeah,
want to?
I think that frequently, as we talked about, it's hard to know what might be causing a particular headache, particular migraine at the time, to know, well, it was this emotion or that emotion or this thought or this trigger. Oftentimes we don't know. The brain can be capricious and can just do stuff on its own. And because the dangerous mechanism in the brain is subconscious, so we can't always know what's happening with it. But I do think it's been helpful to look at the initial onset of migraine and what was going on in people's lives then. Because when you do that, usually, not always, but usually you will find some important factors that point to things that might be useful in life. So if someone started getting migraine after bullying in school, if someone started getting migraine after an assault or an emotional abuse situation, or started getting migraine after being criticized or being embarrassed, those can really be helpful things to help us understand ourselves and what drives us and what kinds of things we might need to work on. One of the men I saw had migraine, and when he got a very first migraine at a very defined time, he was around 19 years old. And when I asked him what was going on in your life at that time, he said, I don't know, nothing. I don't think there was anything. It just came on out of the blue. But when he thought about it a week or a couple of weeks later, he realized that migraine started after his sister told him that his parents were deeply disappointed in him over the choice of major he made in college. So it was a question of criticism, a question of being criticized. And it turned out he was often having migraines when he was criticized at work or criticized by his wife. And so this turned out to be a really important opportunity for growth for him to realize this about himself and how he could work on that and how he could change that to be less worried about criticism and also better able to speak his truth and be his authentic self in speaking to others and dealing with these kinds of relationships. And so it turned out that the migraine was something that was a message to him to guide him to grow and be a better version of himself. And that is an amazing thing when you can find that, situation and use it as a way to be better.
In my experience, I think everyone initially says, no, it just came out of the blue. I don't know anything. And then when we dig around into the storyline, as soon as you kind of make those connections, it's like, oh, could that actually trigger it? And it's like, yeah, it actually can. So I like those connections. When we talk about neuroplastic pain and symptoms, the next step is always to say, What that is that there's no structural or disease cause underneath it.
Mm-hmm.
And migraine, we know, is primary pain
Mm-hmm.
disorder, but it's also called a neurological disease. And so, what I always trying to explain is, but it's not that type of disease that we're talking about. It's still neuroplastic. So, can you just touch on
Yeah.
that why it's such good news of being primary
Yeah.
pain?
Well, when people say, well, it's a neurologic disease, what they're trying to do is validate that it's real. And validation that the symptoms, the sensation, the pain is real is critical. It's nothing could be more important than that. The validating the fact that people who are suffering are truly suffering. It's not all in their head. They're not crazy. It's not their fault. It's not because they want it. They're not imagining it in any way, shape, or form. And that's the reason why people use that terminology, neurologic disease, is because they're trying to give it validity. So it should have its own validity, whether it's neuroplastic or not. To me, the word disease means structural damage. The disease of cancer means structural damage in the body of cancer. And I think of migraine as a condition because, and not to diminish it in any way, but to make it understood that it is well, like you said, primary pain, not secondary. Primary pain means there's no structural damage causing it. Secondary pain means you have headache due to a brain tumor, due to vasculitis, due to meningitis, due to structural damage in and around the head. And making that distinction, I think, is very, very important. The pain is real no matter what's causing it. The validation has to be there. But the terminology can make a lot of difference because the terminology can make it seem like it's reversible or incurable. The terminology can make it seem like it's neuroplastic or structural. The terminology can make it seem like it's genetic or epigenetic. And those things make all the difference in terms of helping people overcome this condition that causes so much suffering in the world.
Yeah. I've been on videos on Instagram and things saying, I don't accept that I have a disease. That don't put that label on me. I don't want it. I don't want, it just sounds like you're telling me again that I'm incurable, and those days are gone. It's actually today starts Migraine Awareness Month. I didn't say that at the beginning.
There we go.
And I have changed that from Migraine Awareness Month to migraine is neuroplastic pain. I put that on Instagram that, yeah, that's what I want to raise awareness of, that migraine is neuroplastic
Nice.
pain, because that's what matters. That's what gives people hope. That's what actually is going to shift something for somebody to understand
Yeah.
that it's not incurable, that this is not our lot in life just because this is what has started. We can unlearn, let me say, your pain.
I love the work you're doing here, Karen. It's really
Oh,
beautiful.
thank
I
you.
love that you're bringing all this into the world in a way which is caring and compassionate and really hopeful and uplifting for people.
Thank you so much. So where people can find you, Instagram, Schubiner. You've got both websites, the Unlearn Your Pain and Freedom from Chronic Pain. Still using
Mhm.
that one, right?
Yeah.
And then you've got the podcast with Dr. Becca Kennedy, The Science Behind the Symptoms. You're a board member of ATNS. There's symptomatic.me. There's tons of information there and different.
Hmm.
You came up with one of the assessments there.
Yeah.
And can I ask, Dr. Chatterjee, you have the new episode coming out soon, or can you mention when that comes out? Or
Yeah. I recorded an episode, a podcast with Rangan Chatterjee in Manchester, England. That'll be coming out on June 3rd.
okay, so any day now, Wednesday. Okay, great. Last one is at 2.9, or maybe it's even at 3 million views now. So yeah, I saw he
Yeah, on that one.
re-released it again after your original. Yeah, that's great. That was a great episode. I send everybody there, the original one. So I'm
So,
excited to see that.
you know, like I said earlier, you put out your work and you just hope it helps people and you hope people who need it find it. And I'm just proud of the work that went into this book and it'll find its path. And there'll be more books after it and there'll be more people who do this work. This work is growing. It's actually a movement of sorts. People the people who find it want to tell others, they want to help others. That's the beauty of this. And we're also doing research to show that this work is effective, and so that modern medicine will begin to see the value of it as well.
Mhm. I do feel like it's a tipping point. I mean, there's many, many books that have come out this year, but it was just sort of like this book at this time with this publisher and Maria Shriver's name behind it and the mainstream power behind that to distribute. I don't know. I feel like it's a tipping point. I hope it's a tipping point. But either way, it's a great book and it's going to be so helpful to so many people. And let me give one plug also to the Chronic Pain Healing Summit that you're a part of. That's coming
Yeah,
up as well. So
yeah,
we'll be in touch
right.
on that coming up in November. And so, yeah, we've got a lot of exciting things coming up.
Thanks to
But thank
you,
you so,
Karen.
so much. I just want to say personally, from 34 years of suffering to
Mm,
find this
mm.
information, and you've been very instrumental in my career of shaping the career and the tools and things that I use and the trainings that I've received from you. So just a huge thank you from the migraine community and all neuroplastic pain and symptoms of all the work that you do and your
Thank
influence.
you. Thank you, Karen. I'm so grateful. I go to sleep every night feeling grateful for being able to do this work. I really do.
Yeah, that's great. Well, thank you.
Did you see that Instagram I put out with my living proof t-shirt?
My heart.
There you go.
I'm wearing my living proof t-shirt, and you can't really see the back probably, but
No, I can, yeah, you can see it.
Unlearn Migraine Pain. Yeah, very proud of that. So shout out to Claire and Sarah.
Yeah, that was amazing. Bye bye. Bye bye.
Is that your brain?
Yeah.
See you later. Thank you.
Take care.